Hello, guys. Welcome to AMC Prep Talks. Today, we are going to do the topic of acute coronary syndrome from our cardiology series. Acute coronary syndrome is a very important topic for AMC, and it is a quite confusing topic when we are talking about the management because AMC loves to test you about what is the initial step, what is the most important step, what is the next step, and what is the most appropriate investigations and all of the questions like that. So in the case of acute coronary syndrome, it becomes a quite tricky it becomes quite tricky. So in this video, I'm going to be explaining about the management of acute coronary syndrome in simple words with the help of ETG guidelines. This lecture is all about the ETG guidelines. So starting with that, let's understand what is the acute coronary syndrome. So whenever the patient has chest pain, we are going to see if the chest pain is relieving with rest. So if the chest pain is relieving with rest, it is a stable angina. But if it is not relieved with rest, we are going to do the ECG. And on ECG, if there is ST elevation, so it is directly termed as ST elevation MI. And there's also the fluctuations of troponin, increased troponin levels, and there are fluctuations. Then we have non-ST elevation acute coronary syndrome, where there is no changes on ECG, where there are no changes on ECG in the patient with chest pain that is not relieved with rest. Then we are going to see the troponin levels. So if the troponin levels are increased, that is termed as non-ST elevation MI. It means the ECG changes of ST elevation is not there, but the troponin levels are increased. So that is termed as ST elevation, and it means that the cardiac muscle has become ischemic and necrosed to the level that the muscle has released its chemicals, but there are no ECG changes. In case of unstable angina, there is pain that is not related with rest, and on ECG there is no finding, and also their troponin levels are normal. So labs and ECG are normal, but the patient is having chest pain with rest. So that is not relieved with rest. So that is the term called as unstable angina. So we have two kinds of myocardial ischemia that are present in the ETG guidelines. So the type 1 is considered to be due to the atherosclerosis that has a history of atherosclerotic disease and the atherothrombotic coronary occlusion, which is secondary to the plaque disruption. And troponin levels in this case rise and fall. They fluctuate with when any one of the following symptoms of acute MI, new ischemic ECG changes, there are pathological Q waves, and there is also an imaging evidence of new loss of viable myocardium, and there is coronary thrombus on angiography. Now, the type 2 is actually termed as the imbalance between oxygen demand and supply. Type 1 is actually the atherothrombotic coronary occlusion due to the plaque disruption. But type 2 is actually simply the imbalance between oxygen demand and supply, and causes can be tachyarrhythmia, bradyarrhythmia, and the heart is not getting enough time to get its blood supply due to the increased heart rate, anemia. The muscles of heart are not getting enough oxygen due to the anemia, respiratory failure, hypotension, and in presence of coronary artery disease, coronary artery spasm, dissection, or embolism. So these also can cause STEMI, and occlusion hence should be managed as type 1 until proven as non-atherosclerotic um, myocardial infarction. So, what is the myocardial injury? Myocardial injury can occur in the absence of myocardial infarction, and in this case, troponin's values are raised, but they do not fluctuate. So, the difference between myocardial injury and myocardial infarction is that myocardial infarction, the levels of troponin are actually fluctuating, but in the case of myocardial injury, they do not fluctuate, and the causes can be same as of type 2 myocardial infarction, also myocarditis, heart failure, cardiomyopathy, non-cardiac causes like kidney failure, sepsis, aortic dissection, and pulmonary embolism. You can check my video on chest pain. I have a video on chest pain from the John Morthak series, and it is a very important video. You can get the differentials for chest pain and the chest pain kind of which is related to the heart. I have linked the video, so make sure to watch the chest pain from John Morthak. Without further ado, let's start our management of STEMI. And the patient of STEMI, the patient has chest pain, which is not relieved with rest, and there are ST elevation on the MI. That is the STEMI. So, very first initial treatment would be to give aspirin. The AMC test you like the sentences of what is the best next step, what is the initial step, what is the most important and most appropriate management of STEMI. So you have to look for these sentences. These are very important, and you have to focus these in the questions. If the question is that the patient has presented to you with the chest pain that is not relieved on rest, and their ST elevation changes in certain leads, so very first initial, what is the best initial step? So you have to mark the aspirin, because aspirin is the best initial step, and you have to give the aspirin before mona therapy. What is the mona therapy? In mona, A stands for aspirin, so it is the best initial treatment. Then we have nitrates, oxygen, and morphine. So after aspirin, you have to evaluate if the patient needs these therapy. Like patient has severe pain, so we can administer morphine. If the patient has decreased oxygen levels, we can give oxygen, and nitrates can also be given. Likewise, but the best initial treatment would be aspirin. So now after aspirin, the question asks that the patient has been given aspirin. Now, what is the best next appropriate step? So best most appropriate next step would be a reperfusion therapy and the PCI or PCI. So after aspirin, the best step would be PCI, and you have to give PCI as soon as possible. But before that, we have to check for the timeline, because plan perfusion therapy is recommended within 12 hours of the onset of chest pain, and if more than 12 hours have elapsed, then reperfusion is only considered if there are signs of ongoing ischemia, viable myocardium, and major complications are there, and the patient is not stable. Now the patient has presented to you within 12 hours of onset of chest pain. Now you are going to see if the PCI is available within 120 minutes of first medical contact. You have to look for these two sentences. PCI has to be given within 120 minutes of first medical contact. First time he presented to your clinic, or first time he presented to you. So it is the first medical contact, and PCI has to be given within 120 minutes of the first medical contact, while reperfusion therapy is to be planned within 12 hours of onset of chest pain. Now, PCI is available within 120 minutes of first medical contact. If yes, then we are going to arrange the PCI. And while arranging for the PCI, we have to give the patient dual antiplatelet therapy. That is aspirin has been given earlier, so no need to give it again. And you have to administer the second antiplatelet drug, and it can be prasugrel, ticagrelor, and clopidogrel. And prasugrel and ticagrelor are actually preferred. Then we have the periparenteral anticoagulation, and it is also done side by side with the PCI, and it contains the unfractionated heparin or enoxaparin. Now we have to see if the PCI is not available within 120 minutes of the first medical contact. Say for that the PCI is not available in your facility, or the hospital that has the facility is far away, so you have far away, and it cannot be approached less than within 120 minutes. So you have to start the thrombolysis. But first of all, we have to see if there is any contraindication to thrombolytic therapy. So there are contraindications to thrombolysis are the closed head trauma, facial trauma within 3 months, or intracranial hemorrhage or stroke history within 3 months. The patient has bleeding disorder, in bleeding diathesis. So these are the absolute contraindication to thrombolysis, and relative contraindications can be the major surgery. The patient has undergone a major surgery some weeks ago. So the contraindications, we have to see for the contraindications to thrombolysis. And if the patient has contraindication to thrombolysis and the case and the AMC test, AMC asks you that the patient has been given aspirin and PCI is not available within 120 minutes of first medical contact, and there is also the contraindication to thrombolysis is also mentioned, what you have to do, what is the best next step. So the best next step is would be the transfer to PCI facility as soon as possible. So this is the next best step in that case. So if now if the PCI is not available within 120 minutes and there is no contraindication to thrombolysis, now you have to start the antithrombolytic therapy within 30 minutes, and it has to be started within 30 minutes along with dual antiplatelet therapy and parenteral anticoagulation. And after the thrombolytic therapy, you have to transfer the patient to PCI facility within 24 hours because a stent has to be placed in the patient with STEMI. So the ultimate management would be PCI. So you have to keep that in mind. So this is the management of stepwise management of STEMI, and you have to learn this table that is given in eTG guidelines, and it is a very important table. I hope you have understood the stepwise management of STEMI. And if you like my video, kindly share among your colleagues and subscribe to the channel. I would be covering the STEMI non-ST elevation MI and the long-term treatment of acute STEMI in the next video. So stay tuned. Thank you.